Dr. Judith Bowman, MD, is the co-founder of Men's Medical, where she leads in functional and integrative approaches to mental, emotional, and behavioral health. With a background in nuclear medicine and advanced training under Dr. William Walsh, Dr. Bowman specializes in nutrient therapy for conditions like anxiety, depression, ADHD, autism, and more. Her expertise in identifying and treating biochemical imbalances such as methylation issues, copper-zinc dysregulation, and pyrrole disorder makes her a leading voice in the field. You may recognize her from our webinar, The Copper Hormone Connection and Hidden Drivers of Anxiety and Chronic Illness in Women. Please join me in welcoming Dr. Bowman. And now everyone goes, clap, 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 clap. Welcome, Dr. Bowman. I know everyone's cheering from their desks. We've got 63 people here already today. I know more are going to be pouring in. And you guys, I'm really going to let Dr. Bowman start her lecture on autism right now. Autism with Dr. Bowman. And here we go.
Thanks so much for the introduction. But you know what? The majority of this, as you are aware, will probably be questions that need to be answered. And so I'm just going to kind of give you the cliff notes of, say, neurodevelopment, particularly in the brains of patients that have autism spectrum disorder. And so keep these things in mind, because what we're really talking about here is an insult that has happened that has caused really a suspended animation somewhat in development, in neurodevelopment. And so what I have learned with Dr. Walsh is that the brain kind of develops from the top down and from the bottom up. And that development has to do with really tubules where the brain is actually connecting with itself. Overall, the brain talks to itself and makes all kinds of highways in terms of how information is going to get stored, how it's going to be delivered, and what is happening, and how it talks to itself and integrates within itself to make things happen in terms of sensory processing, answering a question, mood and demeanor. All of that is really guided by its ability to really network with itself. So that being said, how does the brain really develop? Once again, from the top down and the bottom up, quite literally coming together. However, when there is an insult, and that insult could be, and this is where the controversy is coming into play, is what really causes autism. There may be, I'm going to stop a little bit here, a genetic predisposition. There may be weaknesses in that. There may be a viral insult. There could be just about the time that immunizations seem to be cumulatively making a difference in how this person is going to respond. It could have some influence in that direction. But basically, I think what I'm trying to say is it's a multifactorial scenario that happens that causes this suspended animation and development of the brain. And when that happens, you get presentations that are one seems to be regressive, and that's probably the hardest thing to deal with, to watch your child go from what appears to be appropriate development, mood, demeanor, sensory processing in general, to what appears to be a regressive sort of development. That's probably the most horrible thing to look at and see. Your child was walking, your child was talking. There was mama, dada, and the rest of the things that kind of go with the developmental expectations. And then they stop that. Instead of walking, they start crawling. Or maybe instead of crawling, they stop looking at you and the eye contact is just suddenly not there, as if they're just not there. They're just not connecting. So there's that type. But then there's also the type that never really had a chance to regress, but never really had a chance to develop. And so both are kind of a horror for any parent to kind of go through. And so those are the things that we're talking about today in terms of how to stop that, how to move these kids into mainstream. And probably what you all know is that early intervention is absolutely key for everything. Now, we've treated patients that appear to be on the spectrum anywhere from, I'd say, 18 to 24 months, let's say that, to our oldest, believe it or not, is about 60 years old and has followed us for at least about 20 years or so. And so the question is also not only what can you do to try to get a child to move into a mainstream scenario, but for those that have autism that are way past, say, early intervention, what can you do about those particular individuals? And I'll say there's something that you can do all along the way. Okay, there really is. So that being said, let me bring a couple of things into mind, because this has been a lifelong Dr. Walsh work in terms of what it is that he's doing to help things move along. When kids are past the age of, I'm trying to give you some pearls, um, past the age of, let's say, somewhere between 7 and 10, the odds of flipping that child, excuse the term, but that's what it is, flipping that child back into a mainstream scenario tend to go down, which is why early intervention is really so important. The brain early on is still very, very plastic, particularly 7 years old, let's say, and younger. When we get a child who is at least, say, between 2 and 7 years old, there's great potential for that kid to have great progress. Beyond that time, let's just say age 10, it's not really about buying more IQ points. You can improve in a great extent. In fact, 85% of the kids that have the diagnosis, so to speak, of ASD do significantly better. Those that we get that are so much younger, very often you can't even tell that there was a diagnosis by the time that they are school age or a little bit older. And so we're all hoping for mainstream scenarios. And there may be actually some things that we just call autisms, where it doesn't look like full-blown autism, but there's some little things that are happening that seem to be a little bit problematic still, and those things can still be worked on. So main players here. Metallothioneine, I have to say that. This is one of the things that Dr. William Walsh has worked on, so very hard to find out what the heck does that do with, what the heck does that have to do with autism, along with this so-called magical B12 injection, which got started with, I think, Jim Newbrander. Between the two of those things, what we're trying to achieve by putting those two together is to restart and to finish brain development. Now, here you go. Let me kind of paint the movie for you in terms of what metallothioneine has to do with it, because it's so extremely important. Metallothioneine is a protein, all right? And there's 4 receptor sites that are generally thought to be extremely important. Receptor sites 1, 2, 3, and 4. Now, based on what Bill has studied, receptor site 2 tends to be very critical to complete brain development. However, if you've had an interruption, if you've had an insult in brain development in a child, metallothioneine kind of sits on the sidelines and does not do very much at all. So what is it? So I'm going to try to paint the picture in terms of a little bit of a cartoon. If you remember what a golf ball looks like, put it like that. Golf ball it's a round little thing with a lot of little dents on the side of it. Each little dent is really designated to make sure that the proportion of particular element or mineral is in each particular cell, particularly brain cells and gut cells, believe it or not, in its proportion. Metallothioneine kind of regulates the proportions of so many different minerals and metals. And when it's not functioning the way that it should, it tends to cause development that is far from optimal. So what you get is permeability and loss of integrity of brain and gut membranes. That is not what you want in a rapidly dividing, growing individual whose cells are rapidly dividing and developing into what they need to be. And so when it sits on the sideline, it usually is doing that because of an insult that has happened. Something has happened. And so you get the suspended animation scenario and metallothioneine not doing what it needs to do. So painting the movie for the cartoon, think of this golf ball kind of rolling into the cell of a brain cell or a gut cell and kind of taking I guess you could say, just basically trying to figure out what's off balance here, what's in balance, what's off balance. So it'll say things like, oh, okay, let's look at zinc. Doesn't seem to be enough here. Maybe what we should do is go into our little zinc pocket and put more zinc in. Oh, look at this, copper is way too high. So we should kind of roll around to our little dent that says copper and kind of regulate that. But you can imagine, with all the minerals and metals that are absolutely critical for the development of the brain, it has a lot to go through But if it stops and does not work, what you're getting is dysregulation. So whether it's enzymes, hormones, proteins, and neurotransmitters that need to be developed, that the brain actually needs to work the way it needs to work, those things are just not going to happen. Okay, next kind of viewpoint on what it's really doing. Every single cell in your body basically is its own energy gatherer. It's its own, you could call it battery, so to speak. And, a lot of the development of this actually came out because Dr. Walsh was trying to figure out, why does a battery work? Well, in actuality, your brain cells are each kind of work like they're a battery in and of themselves. And so if there's not enough electrolytes, if there's not enough minerals and metals that need to be there in a particular proportion, it tends not to work the way that it should. So when you cut off that ability, you don't get development in a manner that would be appropriate. And so this is where metallothionein comes into play. It also is a protein that needs to be activated. Okay, this is where we come into the thought of methylation. Okay, enzymes, hormones, proteins, neurotransmitters, they need to be methylated in an amount that's going to be beneficial because they simply turn on or turn off the ability of function. And so if metallothionein, and you kind of heard that word, metallo as in metals, if that is not working the way that it should to actually put things in proportion, minerals and metals, then once again, we have kind of a suspended animation in what's going on. The brain's not getting the energy it needs. It's not working like a battery. And I'll have to give the example of what happens when a battery is losing its strength. The components that are inside are once again out of proportion of what needs to happen in terms of electrolytes and the energy that can be produced. So in autism, you usually get a dysfunction of metallothionein that's just sitting over in the corner, not doing anything. That's going to stop progress. The other one that you get is, well, what the heck does B12 have to do with anything? And a lot of folks are definitely aware that B12 injections, very often we will say, hey, you really need to do this. And the next question is, well, you get B12 out of foods that you eat, blah, 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 blah. But it's actually how it's delivered that makes the biggest difference. And so we generally will say that B12 injections actually work a little bit better than just trying to get them in from an oral standpoint, because what happens is with most things that we take into ourselves, whether it's a drug or a supplement, the liver is going to actually do a judgment call on where it needs to go and how it needs to process and if it needs to be detoxified. So this is one of those things where if by injection it is given, it tends to do what it needs to do. And in case of brain function, B12 combined with metallothionein, if it's working well, tend to help the brain continue to develop in a manner that seems to be more appropriate. And if those two things are in deficit, then we're going to have some issues because no longer can we produce the highways where the brain is actually connecting and webbing within itself to produce what it is we need to do. And so that being the case, those are the two, and there's more, major players in terms of continuing to develop a brain the way it needs to develop. Now, I'm going to call the elephant in the room and say, of course, everybody has heard that, oh my God, immunizations, do they stop, or what's going on with that? Do they cause autism? So I have to kind of go back to the fact and say, okay, autism is a multifactorial scenario. And so there's many things that tend to converge on a developing brain that if there's a genetic predisposition or an insult that simply stops the continued development in a manner that would be beneficial. And so you get a spectrum as an autism spectrum disorder of what might be problematic for something small to something very, very severe. So let me hold it right there. Anyway, ask questions if you need to. We kind of need to get into answering your questions more so than me just explaining what the heck is happening, because I think maybe you'll learn more that way. If you want to start in, I'm okay with that.
I love that. You guys, Dr. Bowman is giving you guys an hour of live Q&A. We've already had 12 really great questions come in, and I know the more we go, we are going to get more questions. So I am so excited to get going. For people who are just logging on now, we are with Dr. Bowman, who is an expert in the field of functional medicine, supporting critical mental, emotional, and behavioral conditions. She studied nuclear medicine, and now she is helping thousands of patients over at Mensa Medical support their mental health, behavioral conditions, mental emotional conditions, all that fun stuff. And we are in the webinar Autism and Neurodevelopment, What Shapes the Brain. You just mentioned so many good things. You know, we have some foundational questions that I want to start with. So how do you definitively diagnose that a child is autistic? This is a question from Jim.
Okay, Jim. Most of the time, what happens is, particularly if you've had kids before, you're going to see how the development is in terms of what you'd expect for a child who seems to be on the spectrum, and there can be variations to the theme in terms of how they present. You don't generally see things like eye contact that seems to be there. Eye contact can start as early as, oh, it depends on the kid. A good 2, 3 months, you start to develop a sense of who's mommy, who's daddy. You start to recognize and look directly into the eye as if you're making a connection. Generally, in kids with autism, there's a side gaze, or I'm not looking exactly at you. There seems to be no way to really communicate. Early on, babies, pretty simple. They cry when they need something. They will fuss, and you can eventually learn what the cues are that they are really asking for. There's not too many things that they will well, they can't talk. So obviously they are displeased over things. They kind of let you know. By the time a kid is somewhere, though, between, let's say, 18 months and 24 months, there's a lot more that really should be going on. And if you go to your pediatrician and you've been following up accordingly based on a 2, 4 months, 6 months visit, 8 month visit, a year, 15 month, 18 months, 24 months, if your child seems not to be where they need to be in terms of developmental milestones, a lot of parents will definitely question as to what the heck is going on and why is that happening. You have to make the consideration of, are there little tisms here? Is this a diagnosis of autistic spectrum disorder? What is happening? In the big picture, by the time a child should be really babbling and talking and giving some sort of a verbal expression, if you're not seeing that, then you really need to question whether or not there needs to be a screening for autism spectrum disorder. It's not always apparent. And let me talk a little bit about Asperger's, because DSM-5 has kind of lumped that one as well into autism spectrum disorder. It is a disorder where there tends to be little tisms. And most people are pretty aware that the social cues don't seem to be there. Sometimes empathy does not seem to be there. It's kind of a pragmatic scenario in terms of speech and language, but I have to make the distinction with Asperger's. Asperger's children will still tend to develop intellectually. With autism, and that's a big difference, with autism in and of itself, there tends to be a degenerative thing going on relative to nerve development and cognitive impairment. And if you don't do something early, it tends to get worse and worse and worse. These are not the kids that if they don't get help, they will not really flip into a mainstream scenario where they can move in a direction of appropriate development. A lot of times, I have to say this, it's very interesting. And I literally have seen literally thousands of children where the story is 18 months, 24 months, it just seemed to happen. I'm not blaming MMR, or for those kids who seem to have a weakness or a genetic predisposition or some kind of a flaw where a final insult pushes them into a regressive state. It tends to be between that time period of 18 and 24 months. And there needs to be, and there probably is some going on, but there needs to be way more research to find out what the heck is happening between 18 and 24 months and around the time that MMR vaccination is given. And we're not anti-vaxxers. I have to put that out there. But there's some kids and there's some folks with a predisposition of weakness that tends to happen between that time period where a regressive scenario is seen. And that absolutely needs to be worked up in terms of, am I looking at autism? Has there been an insult of some type that is provoking a regressive nature or a developmental regression? That's just really what it is. Mm-hmm.
Yeah, so how do you know? How do you know if they have the factors there that are going to predispose them for maybe not being able to handle that vaccination compared to a different child? Like how can you possibly know? You know, we're getting some questions on there. We're getting so many good questions. There's no way we can get to them all. But you say, sometimes you do have genetic predispositions or other things going on. Can parents know?
They can know, the ones that know a little bit earlier are the ones that have had children before and have watched their development. There's other parents that are new parents, and this is the first child. And it's like, well, give them a chance. A lot of times is what you get is give them a chance. Let's just see how they do. Let's go for 24 months, 36 months and see what's happening. And at those times, we're kind of losing time in terms of what we could do to help. Because autism may not be just it. It just could be a learning disability or whatever. It could be a hearing problem. So once you kind of rule out the basics, can they see? Can they hear? Then you have to go for really a screening to see whether or not this is really autism. It's kind of a clinical diagnosis. There is, and forgive me for saying this, but this is how it is. There's kind of an inward sense that a parent gets that this is not an appropriate development. And if you have any inkling at all that something's not quite right, because it should be pretty apparent by going to your pediatrician if they're screening for developmental milestones. If some of those things are missing, then it's time to think about screening for autism. And as long as it's below 7 years old, there's a really great chance that this can really turn around and move developmental milestones forward. There really are. A lot of times you also get kids who have the gut, I call it gut inflammatory scenario where maybe this child was premature. Maybe this kid needed to be on antibiotics early in the hospital for whatever reasons that there were. So their guts, let's bring that up. It's a gut-brain connection. Most people are realizing that there is a huge gut and brain connection. And also, when I was talking about metallothionein, it plays a role in both. And it's metallothionein too that generally does this scenario. And if it's not there, it's not functioning the way it is, then you're going to have, I get an insult and also a metallothionein 2 is not helping to keep the integrity of both gut and brain membranes where they need to be. It's kind of like having a free-for-all. Well, this is where leaky gut comes into play, and everybody's kind of heard of the leaky gut and autism spectrum disorder. It is usually very severe. It is pretty severe in the gut, and it can be just as severe in the brain. And so when you have that, you might have a situation where the nutrients that are going in, regardless to whether they're supplemental or they are from a dietary standpoint, things are not happening the way that they should in terms of what it is they need in terms of the building blocks for neurotransmitters, proteins, and everything else. If it's not there because it's a leaky gut, then you can't get the benefit of what's going on there, and developmental milestones might be a little harder to reach. They just really are.
Let's see. Could you please explain the difference in development between high functioning versus low functioning autism? Question from Tiffany.
High functioning autism is just really have a hard line to draw between, is this just the personality of this kid? Because it seems like they have all the developmental milestones, whether they're physical milestones or mental milestones in cognitive development. There's an edge there that's kind of a hard to differentiate. But usually there's some kind of autism, so to speak, that tends to persist, and autisms that tend to persist. It might be, your level of empathy is not really what I expected to see, or your ability to get social cues not really what I would call very typical for your age group. And you have to consider age as well. Early on, you have to kind of give kids a chance if they're under 10, put it like that. Beyond that, though, there should be some things that really signal, okay, there's some level of maturity that seems appropriate. So when you get this severe immaturity relative to, say, emotional responses and things that you did not expect, you have to start questioning whether or not is this high functioning autism where they have an ability to move on. They seem reasonably, intelligent. Um, or is there something else going on? So there's so many factors that you have to consider. And I can't say there's a hard, fast line that would delineate that. It also depends on the personality of the child. And once again, let's go back with autism being multifactorial. But by the time a child is over 10, there should be a pretty clear line that says that either we have issues or we don't. Now, let's bring things like ADD, ADHD into it, because there is a tendency to want to figure out whether or not this is truly attention focused problem or is this a matter of um, a slightism where attention and focus are problematic. So what I'm telling you is to pigeonhole diagnosis is not necessarily the way to go. A lot of times we tend to do that without really knowing what the problem is. And so you have to be really very, very careful. So a lot of kids that end up with ADHD medication, some of them might not really be having a attention focus issue. It could be a little bit of a TISM, an autism scenario that has to do with attention and focus. And when you put them on medication, very often medication that is given will either show, oh, there was a benefit here or there was not. And for those kids that do not have a benefit, you have to look a little bit deeper into figuring out what truly is the diagnosis versus not. Every child does not have ADHD. And it just seems like we're moving closer and closer to so many kids have ADD or ADHD. Well, not necessarily. You have to be really careful with that. And the last thing that you want for medication for a kid who's not responding to it is side effect profiles, which are totally unacceptable to me, like you get your zombie kid. No, thank you. I'm thinking that medication is not appropriate and maybe this isn't the right diagnosis. Or your kid who is so severely anorexic because they're not eating, which is one of the side effect profiles of that medication. You need to rethink whether or not that is the diagnosis. And so then you need to look at what are the criteria for autism. And that's a little bit harder. It really is because personalities tend to cloud things a little bit. Um, it's a hard one. It is. I'll admit. It's a little difficult to figure out. We need to find out better ways of figuring out the criteria of what it is. Now, kids with Asperger's. Okay. At one point in time, that was actually very separate relative to DSM, I think 4 at the time. Once again, I have to reiterate, very often these can be very, very brilliant people, extremely brilliant, but sometimes social cues and levels of empathy and processing might be a little bit difficult relative to things that are outside of self. Okay. It's very difficult very often for these individuals to think about where life is as they connect to other people and their social engagement. And because of that, they may fall more into an Asperger category, but the intelligence tends to proceed on. They they can be, and very often can be your kid that presents as a savant. I have no idea. And everybody kind of remembers the movie Rain Man. Okay, so here we have a person who is looking absolutely like autism combined with Asperger's and being a savant, who can throw some sticks on the ground, take a quick look, and find out that there's 206 sticks there. That's not something most people can do. What is different about that particular brain that allows that to happen to that person? Okay. And clearly, they look like, in terms of the movies, what autism might look like in a more severe sort of fashion, but I have to say they took some artistic license there and they gave a little bit of emotion to that person. They also gave some abilities that I'm not quite sure fit, but nevertheless, you can get that particular presentation, you know. And what is this stimming? We need to talk about that because everybody wants to talk about stimming. What the heck is that? Um, the brain does not want to be without some kind of activity. It must do something. And so, what tends to happen, rather than I can't imagine what not thinking or not having something going on would be like. And so, what happens is that person will tend to want to entertain their brain in some way. So, whether it's a sideward gaze or looking at a finger or doing something that causes the brain to be stimulated, it's going to happen. And it is so different from one kid to the next. And a lot of times what you'll see, everybody knows about, oh, the flapping and whatnot. Well, that's a level of stimulation. Some people know about sideward gaze or whatever that means. They're trying to stimulate their brain to have some level of meaning. The brain just doesn't go blank, at least as far as you know, not even when you sleep. But it's one of those things where the brain seeks to entertain itself no matter what. It wants to do something. And how that translates from one kid to the next is oh so different. And so when you start to see that, you have to start to question whether or not the diagnosis is what it is. Is this something that's a autistic sort of scenario? Probably. More than less, it's autism. Okay. And so the one thing they got right relative to at least making uh, a title, I guess, would be that it's spectrum disorder. And every Dr. Walsh would always say, listen, one kid with autism is one kid with autism. You can never really take one kid and make a general statement that everybody is like this. They are so not. And they have so many different levels of chemistry. Most of them, this one I will say, when it's truly autism, everything has gone wrong, guys. Everything has gone wrong. Integrity of gut and brain membranes. We're looking at hair analysis, blood analysis, urine analysis, sensitivities of the gut, food sensitivities and reactivities. That everything has gone wrong when it's severe. And I've never seen that fail. And so when we do decide to, okay, let's go after this kid, we're going after everything at the same time because we're not trying to lose more. Brain cells just continue to degenerate. And this is a degenerative condition. And one thing that Dr. Walsh really stamped in our heads, he would say, look, guys, brain cells are dying. Hurry up, get something going, stop the process, and start them to move in the right direction. And so, here we go. That's what it is. I don't even know if I answered your question, but I had to get that out there.
Dr. Bowman, you're doing great. I think the theme is you got to start early. Parents need to be tracking these things. They need to get their kids or their babies in the second they're seeing any of these milestones not being hit. Somebody asked a really great question, and she asked, if you're seeing what are the biggest milestones or maybe biggest signs that you could see by 6 months if you did want to be in there early, if you did want to get them to the pediatrician office. Is there, you say delayed speech, so they're not saying words at 6 months old, but what else is going on that maybe parents can take a look at?
You know what? Eye contact has a whole lot to do with it. Someone who's really relating with you is going to look you in the eye and make some kind of intentional move. A baby, even when they are having that's what you call a frustration of a baby. If they're crying, it's usually because they're wet or they're hungry or some basic need, but they are staring you in the face like, you need to do something, help me, And that's not what you see necessarily with a kid who tends to be on the spectrum. And that very often, these kids, they really do. I'd say 85% of them have really high discomfort or pain intolerance, so to speak. And so they're not necessarily going to let you know or give you a signal that they're having an issue at all, which becomes very frustrating because you would do something if you knew there was something going on. So part of the things of what you expect a baby to do or see or be or whatever, when you see that's not happening, you need to watch a little bit closer. You really do. So you need to learn from the pediatrician or family practice person, primary care, whatever. What should I expect? And those are questions to ask. And when you're not satisfied with the answers based on how your kid is doing versus someone else, then it's time to really go for a screening. It really is. Mhm.
Oh, good answer. So we have so many questions coming in and they're so good. I really want to get to vaccines. I want to get to the testing that you just suggested. First, Jill submitted this question ahead of time, and I think is a very packed question. It might take you a little bit to answer, but what evidence is there for one, a spectrum of biochemical abnormality slash oxidative stress, and or number of potentially at-risk genes to explain the spectrum of diversity within autism? So she's asking, hey, what evidence do we have for these two
Okay.
could be causes?
Okay, so we actually do hair, urine, and blood. And like I was saying before, everything comes back god awful. It does. It does. It's a huge malabsorption thing happening. So that by alone itself just kind of says, okay, so we got a leaky gut scenario. We kind of figured that's going to happen. Also, the major players of neurotransmitters are always usually extremely low, with the exception there's usually too much copper in these kids. There's no doubt about that. For whatever reason that there is, they tend to have big time copper overload problem. And this once again has to kind of go back to the fact that copper is a great conductor of electricity in your brain. Is what? It's a chemical and neurological organ that conducts electricity. And so if you have a copper overload, a lot of what it is that you could think or would think is simply sabotaged. It is. And so copper dysmetabolism usually is almost always a major player for these kids, male or female. And so that in and of itself says that you're not going to process information, your cognitive ability, sensory processing, it's going to be off the wall. It is. And so if you're a young person, okay, a baby, someone between say 2 and 7 years old, you don't know the difference between what seems like normal processing or not. You're only going for whatever your physiology is doing. And if it's off, then it's hard for you to continue to develop in a manner that's going to be acceptable. It is. And so we see copper dysmetabolism, we see severe malabsorption. We see GI tracts that are totally and completely leaky. Everything that can go wrong has gone wrong. We see awful, awful Candida albicans in high levels because the gut is just not doing what it needs to do. We also see a lot of bacterial infections. We see a lot of everything that can possibly go wrong when it's severe, and we have to hit it all. We do. Minerals and metals are not what they should be. Also, the hair analysis that we use generally has a top and a bottom graph, and the top graph generally has to do with heavy metal exposure. These kids very often have really high levels of everything that can simply sabotage brain function. When I was talking about how the brain works and batteries, how the batteries work, well, no, all those things that allow electrolyte balance in the brain are off. And these kids are absorbing large amounts of heavy metal for reasons that I don't even know if I can explain, but they are generally that way. And we have to reduce that in order for their brain to really function the way that they need to. And so by testing, I guess I'm kind of coming around and saying by testing, hair, urine, blood, and other things, the sensitivities to food obviously play a big role. And I haven't even mentioned gluten and casein sensitivity, which tend to be problematic almost always across the board. We have to look at that as well. And so this is where everything wrong that can go wrong went wrong almost always. And it's usually when it's severe, that's usually a severe case of autism. When it's not so severe, maybe it's a moderate case of autism. And when it's mild, maybe it's a lightweight, high functioning autism. But it's by testing. It's by testing. We are a absolutely evidence-based practice, meaning that, yeah, we want to know what your symptoms are. We want to know whether you think this is mild, moderate, or severe autism, but we really want to see what the labs look like in terms of how to at least start attacking what needs to happen. And we tell parents, look, you're in it for the long haul. We don't know how long this is going to take. The younger, the better, the quicker the resolvement. But it's not something that's a fast fix. But honest to goodness, I have seen majority of patients, I have to say almost all of them do significantly better. Some do miraculously better. Some do a little bit better, but a lot of times that's going to depend on the level of severity and how compliant a patient can be. Usually autism kids, fortunately for us, it's been our experience that they don't mind. They are willing to do what's necessary. There's not a lot of pushback relative to them taking their supplement protocols. Many of them have called and said, I know, and these are the ones that are more high functioning, I know when I haven't done it, I know that many of them are, because they're so regimented in their general personalities are so regimented. And when they start a protocol, they generally know when it's supposed to happen. And they feel generally better about it. They feel better about themselves as if they have a sense of something as good as going on here. There's a sense of I'm gaining some level of improvement. And so they literally will be asking, where are my supplements? That kind of thing. I have to,
Wow.
yeah, one example, and I'll stop chatting. And I'll give you two. One kid told me, he says, I know what it feels like to have autism. This kid is now about 14 or 15. I know what it felt like. I had autism. I really did. I was looking through life from a some kind of a mesh, which means, and this is how he described it, I'm looking at life through, I can see a few little pieces. I don't know how they all fit together, but once the veil kind of released, I finally figured it out. I could put life together. I could clearly see what it is that I was missing, and I was able to somehow cognitively repair the parts of the puzzles that were missing. And he says, I had autism. Dr. Bowman, I don't have it anymore, which is an extremely gratifying statement for this kid to say because he's experienced it and was able to get out of it. And I haven't heard too many other kids explain it that way, but it all seems as if a veil has come off and they could see things in totality before they were not able to. And so then they can function like normal people. I have to say that. Okay, go ahead.
So you said, when the cases are the worst, everything's out of balance. There's severe malabsorption, copper overload, too much candida, bacterial infections, oxidative stress, minerals and metals are out of balance, stress is high, all of this stuff. Can you quickly just highlight what testing you're choosing for these types of cases and maybe even a priority too? So if, a kid comes in with autism, like you say, what are you choosing only for that kid versus someone who's coming in, more deeply, and you want to test those. I don't know if that's 5 labs, 3 labs, like just, I'll put them in the chat so everyone can see them, but
I have no
just briefly
question.
go over how you're choosing testing.
Absolutely. We do everything. I'm sorry. It's not one of those things where we're going to look at the gut first, and then we're going to look at the hair analysis, and we're going to look at some of the electrolytes, want to see what's going on in terms of copper, zinc, histamine, urine, cryptopyrrole, zinc level, all of that. We do it all. If it looks like this is autism, we have to attack pretty intensely, and we will look at everything if it's possible. And let's talk about this. Economics plays into this too, and I realize that, we're not trying to drain the bank on anybody, but it's one of those things where if it looks like this is an autism scenario, the sooner you find out everything up front, the better off you're going to be because we are going to attack it all almost at the same time. Now, we will also back up a little bit if it looks like, okay, maybe this is a little bit too much, we're going overboard and whatnot. But most of the time, it is really not the case. We will look at a GI map and find out what the heck is going on with you. Why is there malabsorption? What is happening relative to your calprotectin, zonulin level, elastase 1? What are the critters that are in your gut? What is happening there? Do we need to attack that? And we will. We'll also look at, okay, food sensitivity, reactivity panels. We almost always suspect that gluten and casein are going to be problematic. They almost always are, But we're going to see what kind of foods you are taking in and whether or not those foods are inflammatory to you and contributing to your malabsorption. We're going to look at the other stuff, the basic panel of hair analysis, which probably has, I guess, maybe 30 different things in it. And they are things that are actually metal metabolism disorders in terms of heavy metals, as well as minerals and metals that should be there. And most oftentimes we're seeing that, oh, this kid is not doing a good job at B12. Holy moly. You know, their methylation pathway is going to be impacted by that because that's extremely important. Plus, their cognitive development relative to what B12 can do to finish brain development is going to be impacted. So we also see that. But there's about 30 plus things that we look at relative to hair analysis. So by the time you do hair, urine, blood, you've got a fairly comprehensive look at what and how a kid is metabolizing, what they metabolize. And then you're looking at how well the gut is actually performing through a GI map. You're looking at foods that might be insulting that the parent never knew were playing a role. And of course, that includes gluten and casein. But there are at least 190 or more foods that we look at, I should say, that would be problematic in some kids. And in many cases, those are major players in terms of histamine release. So I did mention this. Most of these kids, I'm going to say 99% of them are undermethylated, which I have not touched. This is an undermethylated, for the most part, situation. We do have some kids that seem to fit the description that are overmethylated. It is a rare find, but it does indeed exist. And I'm very often questioning whether or not this is really autism or some other problem. But for the most part, it's an undermethylated scenario. And I have to mention this, not just us, but Johns Hopkins, Harvard, of course, Dr. Walsh, who's done a lot of studies a long time ago and figured it out, are finding out that some of the increase in autism levels, and I heard it, I think a couple of days ago, that the rate is now 1 in 31. It used to be 1 in 37. Well, okay, 1 in 31, 1 in 37, still too often that it's happening where this diagnosis is coming to be. Once upon a time, it was 1 in 50,000, 1 in 10,000, 1 in 8,000, and so on and so on. What the heck are we doing such that this is becoming just so common? It should not be. There is something that is happening that we may be imposing, and the question is, what is it? So this is where a lot of study needs to be. Now, here are the thoughts. This is just, and I talked about this early on with Dr. Walsh, and he kind of agrees with it. What's going on? Are we doing something? And the one thing that I could kind of come up with that seems reasonable, but not necessarily stamped in gold in terms of what we're doing, is what's happening when we are pregnant. What are we doing? Well, we're taking our prenatal vitamins because we're supposed to. And there is no one on the planet that's going to dispute that folic acid is indeed needed for the development of organs, as well as neural tube defects. We try to keep that down to a minimum. It tends to be extremely helpful, and if it's on board, it's going to happen. And so here's the deal. Up to the first 3 or 4 months, give or take, when organ development is completing itself, that's the period when it really needs to be on board, along with maybe if you're thinking about pregnancy, it needs to be on board. Beyond that time, though, you're starting to deal with the chemistry of the baby. And guess what? You don't know what that is, but you're taking your prenatal vitamin, and as instructed, in many cases it's probably appropriate, but in some cases it might not be. Because as Dr. Walsh would put it, we're looking at a balance between acetyl groups as folic acid has to do with anything, and methylation. So what is not known, and what everybody's doing the MTHFR and blah, 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 what is not known is that there are about 13 to 15 enzymes that are responsible for methylation. Folic acid tends to be a double agent, and you guys really need to know this. It's a double agent. In the cytoplasm of a cell, it will methylate. We're okay with that because it's activating enzymes, hormones, proteins, neurotransmitters to do their job. However, the double agent part that you don't know is it dives into the nucleus and takes off methyl groups from the DNA. So you're demethylating your DNA. If you are demethylating your DNA, you are actually putting a risk factor that changes the expression of many things. If your child happens to be an undermethylator by genetic predisposition and you take off more methyl groups, then your basic blueprint is being changed. What does that translate into? That is the question, and that's where the research really needs to be. And are you putting that child at risk of responding poorly to what is typically a usual visit to the pediatrician's office or the primary care office, such that the immunizations that are provided now there's a scenario that is making them a little weaker. So even with vaccinations and coming down to that, it's like, do we have to give 5 at once or 3 at once? Do we give Pediarex? Do we give whatever the heck it is of the combination? Or do we try to do vaccinations in a manner that allows time to see how the child's going to respond? I just don't like hearing the story over and over and over again that somewhere between 18 and 24 months, the child seemed to go into a regressive phase. Can we just give 1 or 2, maybe 2, I don't know, and see how that is? And there's some immunizations, guys, that we actually need that will save your life, or if you don't get them, you are at risk of just being dead, okay? And I understand that, but it's one of these things, but can we give some time between them such that we can observe how the child is doing and make an informed decision about whether or not the timing for the next one is when it should be, okay? And so those are things that are going to be considered, I hope, in terms of the research that may be done. Okay, and I probably drifted away from what else you were saying, but you needed to know that.
That's okay. We're going to talk about vaccines a little bit more. And then let's go one more question on supplements before we get to the vaccines. I'm not supplements, lab testing. So regarding the B12, copper, other nutrients, like you mentioned pyrrole disorder, how are you testing those things? I included the testing you test. So the advanced metabolic panel, you guys, is blood chemistry in a urine test called the cryptopyrrole to measure pyrroles. And, she's doing a hair mineral tissue analysis by Doctor's Data, and she's also doing an IgG food sensitivity test, including candida and yeast. I think that's almost the most important part. So how are you testing copper and B12 specifically? This is a question from Eleanor.
Okay, sure. B12 test can just be tested. I mean, they can just be tested with a blood test if you're interested in that. But understand this, if you're testing for B12, it is always going to be high if you're supplementing. I don't care if you're orally supplementing or if you're just giving an injection. Understand that. It is going to be high. The good news is that it's a water-soluble vitamin, and usually it just gets peed out, to be quite honest with you, in terms of what's not necessarily needed. But in terms of everything else, you mentioned it right, Caitlin, in terms of what it is, the basic test that we do: copper, urine, histamine, urine cryptopyrrole, ceruloplasmin. And ceruloplasmin has to do with whether or not there's enough on board to keep the percent-free copper down to a minimum. And so that disruption of brain propagation of waves is what it should be. We do definitely want to do a urine, a food sensitivity and sensitivity and candida analysis to find out whether or not candida albicans is sabotaging some of the progress that we're having, because it doesn't do anything but produce toxins along the way, which it really can scramble your brain and also obviously mess with your GI tract. And so those things we really want to know. If they're there, we can go after them. And we usually use antifungals, and most often nystatin, because it's 1, an antifungal, and 2, an antioxidant, and most of our patients benefit greatly from that. So like I was saying, though, we repeat many of the things. There's a serum copper, but there's copper that's in the hair as well. There's a duplicate of a lot of things that we test in the blood and in the urine to find out, how are you metabolizing this? What's going on there? Sometimes we'll do a microbial organic acid test to see if there's a burden of overload, whether it's yeast or some other bacterial finding that is happening in the gut that we also need to deal with. If we test it, though, we're going after it. We are. And this is where both the mainstream hat and, if you want to call it, functional medicine or integrated health medicine hat kind of come into play, because very often, mainstream doesn't look at what's on the sidelines in terms of what else needs to happen for these kids. So, well, that's part of it. What was the other part of the question? I'm sorry. Mhm. I think your mic might be off.
Thanks. I asked you about testing for copper and B12 specifically.
Okay, copper dysmetabolism. So there's a total copper, and then there is a percent-free copper. We're more interested in finding out what the percent-free, copper-free radical is doing to you, because it doesn't do anything but damage tissue. Okay, it also sabotages mental processing relative to cognitive issues. And so what we try to do is, if it's elevated above 25%, then what we try to do is say, okay, from a dietary standpoint, you probably need to increase lean sources for dietary protein to produce ceruloplasmin, which is the protein that binds percent-free copper and keeps it from doing damage. Copper is released as it is needed, kind of a feedback sort of scenario in terms of what needs to happen. Copper is needed for the development of blood vessels. And in terms of children, as they grow, they're going to need blood vessels to support growing tissue. Well, that part is fine. But if it's a high number, above 25%, then you're likely looking at interference of cognitive scenarios, which is to say that those are going to be impeded or sabotaged in some way because of the literal physics, electronics that's going on in the brain. And a lot of times these kids are really high in total and percent-free copper, and that needs to be managed. Some of it is conservative, some of it is what we do in the protocol to capture percent-free copper and keep it from causing damage. Simple as that.
Let's see. Ooh, this is a great question. I wish they submitted their name with it. Can we expect improved cognitive and verbal communication in teens with moderate autism if we optimize diet, lifestyle, and levels of copper, zinc, B12, ceruloplasmin, pyrroles, histamine, vitamin D?
The answer is yes. And so this comes into play. If you get a compliant patient, and compliance doesn't have to be 100%, guys. It can be somewhere between 80%, maybe, and 100%. But with that gives you a little bit of leeway there. If you're dealing with teens, if you're dealing with adolescents in general, you may find that to be a little bit of a challenge. But they're also that group, and I have to say this, many of those kids have said, I can tell when I haven't had my supplements. I can tell that I'm not functioning kind of optimally when I don't do it. If I miss 2-3 days, I can tell. And many of them would rather just stay compliant with what's going on. It's a big whoop-de-doo. That particular part of the age group is just somewhat unpredictable in terms of how compliant they're going to be. Very often, mom and dad are involved, and they're relatively persuasive. You'll get the kid to do what they need to do. And once they find out that they have great benefit by being compliant, very often they become very regimented in that. The biggest group is the group that's somewhere between, say, junior year high school and college. That particular group absolutely will witness that while they were at home, they were doing fantastic. Grades were going up. They were doing well socially engaging. They were just at the top of their game. Then they went off to college. Usually the story is within the first 6 months, after they've kind of fallen off the wayside a little bit, they'll say, you know what, I think either I want to get back on my supplements or I need to be more compliant with them. And they start to be believers in what it is they need. They are balancing social issues, scholastic issues, dietary issues. And if you go away to college and you have all these other options in front of you, they're generally very experimental relative to that. And so it makes a huge difference. And we really appreciate when they call and say, you know, I think I'm going to be more compliant with what's going on and what was happening with me before I left home. And a lot of times it helps them to mature to a state where they're very more accepting and what it is they need to do to kind of keep themselves on track. Besides from that, there is a great upsweep of grades and overall functioning when they stay on board. It's a definitely support, put it like that. And they suddenly realize that. And they really want to feel the best way that they can feel. Plus, there's great physiology that comes along with it. So the side effect profiles of what it is that we do actually contribute to really great physiology and just good physical health. It really does. So it's a comprehensive approach. Mm-hmm.
How are you able to help compliance when kids are either young, like too young for that type of awareness, or as you said, leave the home and then they realize they don't feel as well with supplements, especially if they're taking, 1, 2, 7 different pills.
Yeah.
How are you able to support their parents or that child themselves?
Okay, reality check. Sometimes it's a little bit of a compromise. Sometimes we have to target in on major players depending on how they're tested, and we will reduce the protocol with a few little things not there just so that it's easier for them to do. Level of support, targeting those things that are most problematic is the way to go. And very often we have done that. We have, after about the first couple of follow-ups, we see, okay, this is where we need to target in on those things that are really recalcitrant to change or really need to be helped. And so we will target those protocols towards that. And very often is very much so acceptable. They want to do it, but they just think that the amount of supplements that might be required or needed, so to speak, are just too much. And so you do the best that you can do. This is not one of those where we have situations that seem like they're just too overwhelming to do. No, we'll work with you. We will, and try to see where we can kind of slim down to the basics of what it is we think you need. And without compromise, there's some things that aren't broke that we're not going to try to fix. Those things we'll leave alone, even though at times we'd rather see some of these smaller items that need to be there as support items. We'd like to see them there, but they're not necessarily the major players. And so we'll work with the person who wants to do it and do the best that we can, put it like that. So it's just not carved in stone that if you have a particular protocol and it just seems overwhelmed by it, okay. Bottom line is you can still benefit by going to the brass tacks. And that very often is what we do rather than some of the smaller items that we think would be great cofactors for you, put it like that. So we'll work with the person.
This was our most upvoted question. Thank you guys for upvoting. Please continue to upvote so we can answer as many questions that you guys want answered as possible. This is a question by Steph. What is not working about metallothioneine? Is metallothioneine low?
Metallothioneine is low or not working well. Okay. When metallothioneine is low, like any other protein, enzyme, hormones, proteins, neurotransmitter, it is a protein. And it will sit over in the corner, particularly if you have a person who is undermethylated, because it too needs to be activated. If it's not activated, it will just sit over in the corner and not work. And this is where, when I say activated, I'm talking about the methylation profile, meaning that this person has low methylation. It has low activity in terms of turning on enzymes, hormones, proteins, and neurotransmitters. And since metallothioneine is a protein, just kind of sits over in the corner and just kind of waits and hopes the methyl groups will come along and move it to where it needs to be and what it needs to do. So what do? Most of the time for people, and this has to do with both autism as well as Alzheimer's disease, okay, is to try to turn on the activity of metallothioneine 2, which is to say that if we can regulate the enzymes, hormones, proteins, neurotransmitters, metals, and essential metals that need to be in their proper proportions in any cell, in every single cell from the gut to the brain, then we get to some level of improved cognition, period. And there's that little likeness between autism, believe it or not, and Alzheimer's disease. There really is a little bit of a similarity in terms of what has gone wrong. Okay. And more so in Alzheimer's disease, it's a okay, some of the highways that used to help the brain talk to itself and connect have been shut down. And yes, there's the theory of plaques and tangles and the whole 9 yards of that. We get that. But some highways are still very much so open. And what is still needed is regulation of those particular cells that have been seemingly shut down or without support of what they need to function well. And this is where metallothionein, if you can activate it, it'll rev back up and try to appropriate what needs to be there in terms of electrolyte function or making the battery of every cell work the way that it actually needs to work. Okay. And so in terms of autism spectrum disorder, it's a matter of, well, this is a plastic brain. We can certainly do this. The highways are clear and we can kind of do what it is we need to do to help them to work well and have the brain talk to itself. In terms of Alzheimer's disease, it's a matter of, oh, they're just deficient and haven't been around for a while. So we need to put some things in place to kind of reopen those highways that need to be there so that the brain once again can talk to itself, network, and move forward with what needs to happen. And in terms of that one, the latter, Alzheimer's disease, it's a matter of gaining some level of stability and not worsening because both are neurodegenerative conditions. Okay. And so we're trying to patch that up and correct it.
Mhm.
Mhm.
Mona just wrote in the chat, you guys, metallothionein is also zinc dependent, and low zinc often accompanies high copper and always is a part of pyroluria. Would you
That
agree with that, Dr. Bowman?
I would agree with the exception of the pyroluria part. That just tends to be one where if it happens long enough, pyrrole disorder will develop. I would agree.
Interesting.
Yeah. Pyrrole
Excellent.
disorder. Just real quick here.
Real quick here, let's go into pyrrole disorder.
Yeah,
DHA's core test, the gold
there you
standard for
go.
cryptopyrrole analysis.
Absolutely. Pyrrole disorder, by definition, generally you would have a deficiency between B6 and zinc. Oh, why the heck is that important? Well, B6 and zinc are the rate limiting steps to the production of neurotransmitters, guy. And so it's one of these things where the brain, electronic and chemical. So two things can go wrong. In terms of the electronics, well, okay, copper conducting a wave, whatever the electronics is that gets to the bottom of the cell, the bouton at the end, they have to produce neurotransmitters that are actually in a particular code in order to make the next cell respond and send the signal forward. Okay. However, those are neurotransmitters. Those are neurotransmitters that are being produced, and they have to be produced in a particular way, in a particular code. However, the rate limiting steps for the production of neurotransmitters depends on the level of both B6 and zinc. Okay, so if you have enough B6, if you have enough zinc, you're going to be able to produce that code to signal the next cell to fire. Okay, if you don't, there tends to be the development from a manifestation standpoint of anxiety, of panic, of paralysis to function because you can't think it through. So your cognitive ability isn't there, and your ability to solve problems is not going to be there. Your overall sense of well-being is not going to be there. You can't produce serotonin in amounts that are going to be beneficial. So you're feeling bad. You can't even produce gamma-aminobutyric acid simply because that's your calming neurotransmitter that helps you to manage the situation. Calm down, calm down. We're going to be able to think through this. Well, you can't produce it. Not in an amount that's going to be beneficial to you. You're not even going to produce necessarily dopamine. Well, dopamine's one of those, oh, hey, life is great. I'm feeling great. This is wonderful. I won the lottery sort of position. Life can never be better. However, you're not going to produce it in an amount that's going to even help you. Okay. But what you will produce is the overriding neurotransmitter, adrenaline. Okay. That one says, hey, if I'm feeling bad, I tend to get anxious, might get panicky. And so you turn out to be more paralyzed to function than anything else. And that can happen with anybody, not just with autism spectrum disorder or whatever disorder that's there. Anxiety and the production of norepinephrine and epinephrine tend to be problematic. But if I were to relate that to what goes on with people with autism, okay, and the fact that they're usually high copper levels, then you have to know that copper in the presence of dopamine tends to turn dopamine into noradrenaline or adrenaline. So they're always on fight or flight. Okay. And so that in and of itself is not a good scenario. And so they're nervous and they're anxious and they're rocking and they're doing whatever it takes and they're stimming because of all the above. Okay.
ADHD and autism.
Sure.
What are you recommending for patients with ADHD that have an MTHFR mutation? And is what's causing ADHD also causing autism?
Um, Handy, put it like that. And sometimes the diagnosis is a little bit flirty, meaning that we're not really sure that it's true ADHD or if there's a minimal metabolism disorder, put it like that. Very
Mm.
often you might have, there's different reasons why you have attention and focus issues. Sometimes we're finding that those are copper toxic people, which means that because they're producing so much noradrenaline that's turning into adrenaline, that it's hard for them to focus on anything because they're kind of in anxiety, fight or flight, and a little bit on the stressed side. That could be the reason. They could truly have ADHD, and as you know, ADHD medications tends to what? Increase dopamine levels so that you have a time period of where it seems as if you're able to focus better. Okay. However, if dopamine levels are in an environment of high copper, then we once again are shifting back to more adrenaline production, in which case that could be more of a problem versus not. But for the time period that it takes, whether it's something that you're taking early in the morning, your ADHD medication to give you focus and attention, that's perfectly fine. And we really don't shun the idea of, oh, okay, maybe you really need to have the opportunity to have attention and focus because your scholastics depends on it or your job depends on you having a much better efficiency in terms of executive function. Go ahead and do that. It's not the most scary drug in the world. It can be, depends on what your response is. Okay. But very often we're finding that there's chemistry associated with that ADD or ADHD. In which case, if that's the case, then we're going to try to help balance your chemistry such that one of two things. You can go to the lowest effective dose of your medication, or perhaps you don't need it anymore. Okay. Dopamine, in terms of manufacturing it, maybe that's a problem for you. One way to do it is very often to use tyrosine, which is part of the dopamine pathway in terms of production. Maybe that actually works for you. Maybe you were just low on tyrosine. Maybe that was it. And so those are things that we would offer at least as a trial to find out if that was part of the problem. Or if you just simply have low production of neurotransmitters, in which case, if we can solve that and give you the building blocks that you need to function, then that's what you do, as opposed to medication, which in and of itself possibly would provoke side effect profile that's not so accepting. Put it like that. Mhm.
We had a lot of questions come in about B12, so I'm going to try and just throw them out there and just tell us what you know about B12 and helping that. Jim's asking, can we use liposomal B12 for kids instead of injections? Is that the alternative to needles? And then besides those injections, are there food-based natural ways to prevent anger tantrums via miscommunication? What other minerals, vitamins, magnesium? You let us know. Shamal is asking this about anger specifically with autism.
When I was talking about cofactors, magnesium is definitely a cofactor that will help a lot of folks. Now, in terms of natural ways of attacking this, once again, depending on the testing that we do, that might determine where some of the holes are or not relative to what's being absorbed or malabsorbed, in which case we're going to suggest that's what you use or do. Natural ways of managing it also have to do with what's insulting your gut versus what is not. Okay, what's causing inflammatory changes that's producing malabsorption, and can we fix that? And then once we fix that, is your absorption level of what it is that you need, whether it's dietary or supplemental, it's finally kind of solved. So there are many different ways to look at it. We try to research them all to figure out what's culprit Is it your gut with leaky gut? Is it the fact that you just simply don't have enough of the building blocks on board to do what it is you need to do? So by testing, that would probably be the answer. We get to figure out how we want to approach what's going on with you. Okay. Mm-hmm.
Let's see. I want to do a vaccine question because we got so many in.
Let's do it.
Let's see. Ooh, this is a good one and relates pretty well. Autistic children can have mothers with poor immune function who also have low iron and copper levels are dysregulated. Because they're metals, what are your thoughts on metals and vaccines being the insult in utero?
I'm going to say yes. Okay. That could
The
very well.
answer is yes.
The answer is yes, because very often when we do a history, we're going all the way back to the pediatric history of what's going on with the mom. What has been a genetic predisposition? What did her chemistry look like? What kind of things did she actually go through in terms of her experiences? And what has been transmitted to this child in terms of genetics? Bottom line, not rocket science. Mom, dad, you, okay? And so we have to kind of figure out what is likely a genetic predisposition. Our best studies have to do with, okay, we've done mom, we've done dad, or at least we've done one of the parents. By doing one parent and actually one child, it becomes pretty clear, I hate to say it, what the genetics of the other parent was. Put it like that. And so, because we can interpolate what the heck is going on, very often we see that, oh, so this child was from a mom who had a copper dysmetabolism and who was estrogen dominant. And so, because she's got a copper dysmetabolism, this little boy or this little girl might present with ADD, ADHD sort of symptomatology, which means that let's just take a peek at what their labs look like. And bingo, there they are. You know, mom had high copper levels, estrogen dominance, postpartum depression, postpartum psychosis, whatever the heck it is. And so those ring big flags to us that say, oh, hey, this is what's going on here. And very often we may have a parent actually do their chemistry. When there's more than one family member that actually does their chemistry, it really increases the efficiency of what we do because we're looking at the genetics that has been just kind of moved on down the line. And particularly with females, and that's a whole nother lecture's worth, there tends to be a genetic predisposition along the female line, particularly in terms of copper dysmetabolism. When that is transmitted to the male, though, okay, what you will see is a kid, let's say a male who is oppositionally defiant, extremely impulsive, um, attention and deficit disorder. Those are the kind of things that you actually see. And what he will do when he's old enough to have kids himself is take that genetic predisposition and transfer it right back to the female line. So there tends to be this X-linked scenario for the most part. And a lot of efficiency, like I said, can be gained by doing more than one person within that family. It's not a mandate, but it's very helpful in terms of we know what we're looking at now. Okay.
Wow, that was a great answer. Okay, here's a question. I'm sure many of you have heard of Julie Matthews. Julie Matthews is a functional nutritionist in the field, and she specializes in nutrition intervention for children with autism. She just released a book. You should check it out. I know that she could answer this question, but I want to hear from Dr. Bowman. What are the foundational basics that caregivers could start with from a nutritional perspective to help these kids?
Okay. Um, when it comes to autism, let's just start with that. Make an assumption that this kid's probably going to be gluten and casein sensitive. That's just how it goes, because the majority of them will be a little gluten and casein sensitive. So what does that mean? It means that they cannot, for whatever reason, break down those particular components into the nutrient components. So the amino acids that are produced or whatever, it's just not really happening. And what is produced is an inflammatory change in the gut. Bottom line is, if you have an inflammatory change in the gut, one of deficiency, then you cannot get on the building blocks that are necessary for you to function well. Simple as that. If your gut can't absorb, what do you have for building blocks? How are you going to get the zinc? How are you going to get any of the nutrients that you really need in the manner that you need them? And here's the other problem. If it's a leaky gut stuff simply means that you might get an autoimmune response to whatever is in there because it's moved to an area where your body thinks it's an inflammatory component or some foreign substance. Okay. When that happens and you get antibodies produced against it, it just makes a bad situation worse relative to your ability to absorb much of anything that's going to be helpful. And so make an assumption. And if it looks like you are benefiting from limiting gluten and casein, okay, fine. We also have some things that, in case they're dietary infractions, because you can always be sure about where you are and who's preparing food and what's going on and what's in it. Okay, we do have some options that will help you to break down those particular substances. AFP peptide, which works on gluten and casein to break it down into its nutrient components, okay, might be very helpful. But there are certain things that we have and we do when we know that there's infractions. However, it's best to avoid or limit things that are looking like they're more inflammatory as a problem, okay? Not, by the way, not all autistic children are gluten and casein sensitive, but we will check that out first before we just say, okay, go for it. But what has been done to the food chains these days, we have to pay attention to. Bodies are not really recognizing gluten as being what it used to be long ago, before GMOs kind of came to be. And before we've changed a lot of things and developed a lot of genetics with the food that we eat. Some of our bodies are not recognizing it as food, unfortunately, and they're producing antibodies against it. And so we have a lot more resistance in terms of things that are inflammatory and things that are actually absolutely beneficial or nutritive, put it like that. Look at the corn these days. I love corn. I do. But it's gotten so sweet. It's turned into candy. It
I
really
know.
has.
It's very
And
sad.
that can't be good. It just can't be. And so we have to, we know there's a lot of marketing involved in our food choices. And what used to be extremely nutritive, some of it still is, some of it is not, and some of it is just wasted calories of pretty food. Okay?
Mhm.
So it's a lot to
When
be.
you're running that IgG food map with candida and yeast, Sophie had a very upvoted question. How are you treating candida when it's coming back that way?
Okay, first of all, understand this. There's no way that you're going to get rid of all the yeast that is, okay? No way. Don't even think about it. We inoculate ourselves every day. Don't forget that your GI tract is from the mouth to the anus. It is an open tube. Okay, sticking your finger in your mouth is going to mess up some stuff. Eating a beautiful blueberry with a lot of flavonoids and wonderful things. The little frosty stuff on the outside of a grape or a blueberry, it's yeast. That's how we make wine, okay? It's going in. It is. Yeast is one of those things that has a slow growing rate. It's going to be in there. You're never going to get rid of it. The problem and the question is, when does it become a burden? And let's hope that the type of yeast that's there is not the type that really gives you more of a problem. So if it's Candida albicans, we have an issue, okay? In which case you really should consider getting rid of that. The best way that you can. Now, there's a couple ways to do it. This is where you're wearing your mainstream hat and you're wearing a hat that's functional medicine or integrative health or whatever it is. You can do it from a conservative management with items that help you to get rid of yeast or keep it under control. You can use oregano. You could use Candida cleanse. You can use caprylic acid, which is wonderful in terms of that, of helping you to control the yeast that is there. When it's really bad, though, you might have to put on your mainstream hat and use something like nystatin, or you may want to go for a short course of diflucan. Bottom line is, reduce it to some level that is acceptable. Okay, it's slow growing in the first place, but reduce it to a level that's acceptable so that you don't have the toxins that are produced, okay, in large volumes that are going to cause you problems. And so that's what we do. Nystatin, on the other hand, is an antifungal as well as an antioxidant. And so that tends to be one that we will absolutely um, request that you use. It can be used probably more safely than any of the other antifungals. And as long as it's staying in the GI tract while you're trying to do other things to help with autism or any other condition, it will also give you antifungal plus antioxidant properties. And sometimes I have had patients that have asked if they could just be on that stuff forever because it's the best that they've ever felt. It's not about staying on it forever, however, it's about getting to a place where the burden is low, the toxins produced from Candida albicans are no longer in the formula of what's going on with you. And so a lot of people feel a lot better. Their dietary urges in terms of what it is they want, their sweet tooth of satisfying that tends to go downhill. And that's really a benefit, believe it or not. Mhm.
Mhm. Hey, can you quickly mention the name of the product you use to break down the gluten and casein?
Oh, A as in apple, F as in Frank, P as in peptide, as in P.
Yep,
Um,
Katie got it, you guys. AFT peptidase. Perfect.
Houston's. Houston's produces that. They have chewables, they have whatever formulations they have of it. It's a really good product, such that if you don't know if you're having dietary infractions, hey, use it, and it will help you to break down your gluten and casein
Mhm.
into what should be a nutritive substances in terms of the amino acids that should be produced. And in that way, you avoid the I call it the after the cake and ice cream at the birthday party, when all the kids lose their minds. Okay, you can avoid some of the sequela of what happens there because you're actually breaking it down to its nutrient component as opposed to the inflammatory component. People that are casein and gluten sensitive are people who cannot break it down. They break it down so far, but what they break it down into is inflammatory as opposed to its nutrient substance, which probably consist of an amino acid or protein that you benefit from. And so by using AFP peptide, you bypass, okay, the step that would not allow it to break down. Mhm.
Awesome. We've had a couple questions about PANS, PANDAS, and ASD. Can you quickly give us the rundown there?
Oh, absolutely. It's kind of an offside, but it's one of those things where you can have so-called normal people that were insulted by something, particularly staph or strep sort of scenarios. A lot of times these people stay in a funk. They do. They've been insulted by that. And so what you want to do is very often, and there's many tests. One of them, though, is an ASO, anti-streptolysin antibody, to see whether or not the levels are still elevated. Those patients very often need to be retreated. They do because they're harboring strep somewhere, and very often it's in the GI tract that simply is reseeding their symptoms. Okay, and so when that happens, and we've done folks, even within our own office, that have had this happen to folks, grandchildren, children, whatever, and they actually needed retreatment. Because with PANS and PANDAS, you can get a total personality change. You can get oh gosh, mood, demeanor, even some levels of what seems to be kind of a psychosis. Just totally loss of personality in a bad direction, whatever the heck that means. And something needs to be done because the toxins that are produced are sensitive to that person, and they generally will not do well until you fix that. You know, some things harbor and stay in our bodies. They do until you get rid of them. And very often in that particular case, until you do, very often they will provoke a personality change that is not at all good. Let's just leave it at that.
Aren't blood tests simply identifying additional symptoms or consequences, but still not the cause? Does supplementation really do anything but provide a temporary environmental improvement, which may not do anything to structural malabsorption? This is an amazing question, Philip.
Yes,
I
it
know you've been to our
does.
webinars before, so she's going to, it's good. Let me repeat it. Aren't
Yeah,
blood tests identifying additional symptoms or consequences, but not the cause? So does supplementation really do anything? Because
glad
it's
you asked.
only providing temporary environmental
I
improvement.
am glad that you asked. Okay, first of all, okay. The reason they often say, and you will hear this, oh gee, vitamins don't do anything. Well, no, they don't. You heard that from me. I'm talking about your over-the-counter. Okay, let me just grab a multivitamin. Let me just grab this so and so and so and so. Well, generally, what is happening is what you gathered or tried to grab is a recommended daily allowance of what is needed on a regular basis. In other words, you have at least this much going into your system every day, and hopefully it's going to help you. Okay, that's what it really means. Those are not prescriptive therapeutic doses at all. In other words, someone who has, let's just go mainstream for a minute. Someone that has a thyroid dysfunction, okay, and they're hypothyroid, they're going to need thyroid uh, hormone. Well, there's nothing over the counter that will allow a level of functionality for that person. They need a prescription of what is therapeutic. Okay, so the bottom line is if you test and see where the deficiencies are, okay, meaning whether it's nutrient supplement or whatever the heck, whatever your chemistry is, you need a prescribed, appropriate amount of what is needed for you to manage and overcome what the problem is. So-called over-the-counter vitamins generally don't work for people who have special issues, okay? Which is why we're evidence-based practice, meaning that we need to test you and find out where your deficiencies are. Some things are going to be overkill. Some things are going to be way under what they should be. And then we can appropriate what the heck you need in order to manage that. So what we provide is a prescription, a medical prescription from a nutrient standpoint, what it is you need to solve your issues, okay? Because in general, you can try all you can in terms of one size fits all, and that is the problem. One size fits all does not work for everyone. People are individuals with individual biochemistry, bioindividuality, and because of that, unless you test and find out what the problems are, you really can't recommend what it is that they need, okay? So it's one of those things where, let's take a diabetic first. Everybody knows that. We go mainstream, okay? There are diabetics that are extremely brittle, just as brittle as heck. And then there's ones that are just pre-diabetics, I'm just pre-diabetic. Well, okay, all right. Which means that the what is needed, the requirements of what you need might be different from someone who's extremely brittle. And that's going to require a prescription that fits you, okay? So that's where it actually comes into play. In general, over-the-counter, one size fits all does not solve the problem. Maybe for somebody, maybe it's a perfect protocol for somebody, maybe so. But for most cases, it is not the case. You really need to check a biochemical individuality to find out what the heck is happening, and then appropriate with your appropriate formulation for that person. And that's just how I'm going to answer that.
That was great. Bonnie has a question that's being upvoted. What do you know about the FRAT test that identifies a folic acid issue? And if fixed with new medicine, could result in a nonverbal child being able to speak again?
There are some people with autism that actually tolerate folic acid just perfectly fine. And by the way, I give you this one. There hasn't been a really perfect folic acid test that we have been able to rely on. And that's for the last 20 years. Simple as that. Okay. But there are some kids with autism that absolutely can indeed process folic acid without much problem. The question is this an undermethylated child versus a child who is overmethylated? There's that one exception of what appears to be autism with the overmethylated kid, okay? And so until you just test them once again and see where they are, you don't really know what's appropriate and what isn't. As simple as that. Okay, so let me talk a little bit heady for you, okay? Relative to what Dr. Walsh has taught us over the years, what you have is a balance of acetyl groups secondary to folic acid use and methylation groups. It's a war, okay, between folic acid groups and acetyl groups, and whether or not folic acid is helping to methylate things in the cytoplasm of a cell, and whether it's going into the nucleus and changing your DNA blueprint. Okay. And so then when one is out of balance, you need to find out what the methylation status is of that child, and then you'll know whether or not folic acid is actually appropriate versus not. There are some people, and it looks really weird for us, but it happens periodically, where they need a little bit of the methionine pathway and acetylmethionine pathway, in addition to a little bit of folic acid. Okay. And it's like it happens very rarely, but it does happen. And there are those group of people that actually need both of the balance between the two to function well. So once again, it kind of comes down to testing. And I'm gonna admit, after doing this for 20 plus years now, it's one of those things where I'm even astounded that there's those exceptions. And so it's one of those things where if you test and find out what you need to know, you can appropriate the appropriate therapy as needed.
Mhm. Sounds like individualization is key, right?
Absolutely.
Biochemical individualization, you guys. Jim has a question. This is along those same lines. If a parent gives their autistic child methylfolate and their explosive behavior stops,
Mhm.
what does this mean?
It's one of those kids that needed it. Simple as that. It's one of those
Yeah.
kids that tolerates a bit of folic acid. And very often,
Yeah.
you may have heard that folinic acid for some kids is something that you can provide because they simply had a problem with breaking down folic acid from folate or folic acid style, or folinic acid helps them to break it down. It's already broken down a little bit more for them, and it was how they had a deficit in processing folic acid. And so we also get that occasionally, we do. And so many times, if we really want to be a little more efficient with some of our patients, we will say, well, no, let's do folinic acid, particularly in the autism community, because not all kids with autism on the spectrum have a problem with folic acid. Many of them really can manage it and manage it well. Don't get this wrong, okay? When you're talking extremes of anything, you need to be questioning about whether or not this is actually real. When you go extreme on one side or the other, something's not quite right. There are going to be exceptions to the rule, and you need to be able to realize and accept the fact that there can be. And so we have several kids, no, I would say several, there's a whole bunch. I'm sure they're in the thousands that manage folic acid just fine, just fine. Understand this also with MTHFR and many other genetic testing that is there. Um, because something is because something is written in your DNA does not mean that it's absolutely going to be manifested. And I have to go back to the fact that we all carry, believe it or not, 6 to 10 lethal genes. And if you are alive right now, it's not because the uh, phenotype or the expression is there at the moment. So there's your genetics, there's your blueprint, and there's what's being turned on or turned off. We have so many genes that are so inactivated, it's not funny. Okay. And it's sometimes you have what I call genetic syndrome, meaning that genes talk to each other and they will influence what other genes do. And there's something called, as you guys probably know, epigenetics, the environment imposed upon your DNA. The environment imposed upon your DNA can activate or inactivate certain genes that are there. So that doesn't mean carved in stone because your genes say, this is what I am, is what your genes are doing. Okay. And I often put out there, here's one that everybody might be able to relate to. And I don't know if you guys know this, and I hope I don't get in trouble for it. But Jamie Lee Curtis, okay, is an XY. All right. That is a male genotype. When she was very young, she had testicles removed from her abdomen because she was XY. Okay. That is a boy. Okay. She is a phenotypic female in every single way. And she is indeed that. All right. They had to remove the testicles from her abdomen simply because you get cancer, all right, from testicles that cannot descend. All right. So her gene pool says she should be a boy. She is clearly not phenotypically. Well, that goes for anything else that is going on. If you guys want to look that up, you can. All right. I had to do an entire paper on her in residency. So our particular
Wow.
is true. But there's other things where, okay, I have a blue-eyed gene. I have brown eyes. What? Okay. So many things that are there are the environment imposed upon your DNA and depends on what's going on. One of the other really typical things that happens is cancer. Smokers are the epigenetics where the environment upon their DNA may increase their risk factor tremendously for the development of lung cancer. But if they had never smoked, their risk factors would have simply ignored that. And that gene that would have probably caused a phenotypic, means actuality, manifestation, would never have been seen. So just because you have a particular blueprint doesn't mean that the genes have been activated. But once you have the environment imposed upon your DNA, maybe, maybe not. So it's don't get too locked in. I'm telling you, there's a lot still to be known. I know we know the genetic scenario and the genome and blah, 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 blah. Buy into it to an extent. It's done a beautiful thing relative to drugs and what might be beneficial for you versus not. Okay. But it doesn't mean that because you have that, that you're manifesting. It's like, what are you doing? There's your DNA. But what are you really doing? What is your body actually doing though? You know, and whatever genes are involved, because genes talk to each other, and some manifest as a group. And when they manifest as a group, generally the conditions they produce are syndromes. Okay, syndromes, meaning there's several things that kind of come along with this whole clinical presentation. So Down's children, they have certain things we have to watch, and this is where I put my mainstream hat on. They have neck problems. They could have leukemia problems. They may have all kinds of different things that generally come with the syndrome of Down syndrome. And it's the activation of a gene pool that may or may not happen. And there's some super high functioning Down's children who, if you never saw them and you heard them speak, you would think they're just a typical normal person, you know,
Wow.
as they can be. So
Hmm.
biochemical individuality is everything. It really is. And the best thing you can do to the best of your ability, and as long as there's tests to try to figure it out, is try to figure out from a biochemical individuality who the heck they are and what it is you want to do to try to help them. And so that's what we try to do.
Hmm. Yeah, you guys, Dr. Bowman's over at Menza Medical, and her and Dr. Menza himself are reversing autism. It is possible. They are really giving so many children and adults too, a chance back at a lot of things that they may not have had otherwise. So we've been here for almost 2 hours. It's been an hour and 45 minutes. Dr. Bowman, how you feeling? Do you need a bathroom break? Do you need some
Hi,
water?
no,
Do you
I'm
want to keep doing
okay. No,
questions?
I'm really okay. This is something that, like I said, I've done this for 20 years or so. Um,
Yeah.
I put on the mainstream hat as well as the, if you want to call it integrative health sort of scenario functionality, whatever it is. But it's one of those things where I'm very passionate about what it is that I do.
Yeah.
And every single patient that comes in, they are a unique individual, and we have to figure it out. I realize also, I'll admit, there's some economics that plays into it. And particularly with autism, you're in it for the long haul. You are. The oldest patient, like I said, is about 18 months or so. The oldest patient that we have is probably almost 60. Almost.
Wow.
And that particular patient, I know there's many that are in between, but that particular patient is now helping his mother, who's probably 80 plus years old, find her way. He's very regimented. He knows where he's going. He can speak. He tries to do everything to keep a level of stability. And that's been huge because we've been following him since he was about 40. And so there's like, of course, there's something you can do. So if you're not 4 or 5 years old, don't forget, these are individuals who still have some level of need in terms of other things that happen in life. Life throws darts at them like anybody else. They get depressed, they get anxious, they have challenges as well. And so those things in terms of mood, demeanor, ability to go out in public, to just function, they still can be helped. What we'd like to see is early intervention so that folks can
Hmm.
move into a mainstream scenario, and hopefully you just can't really tell. you know.
Sure. Yeah, you keep saying that. You keep saying early intervention is so impactful, so valuable. How about parents with the MTHFR mutation or sulfation issues or oxalate issues? Are they more likely to have a child with ASD or ADHD?
Lots
Um,
genetic predisposition toward most things. It's the only thing that you can really say relative to MTHFR. And guys, please understand this because I'm thinking maybe Dr. Minson might talk about it maybe next time around. MTHFR is the largest of the enzymes that contributes to methylation. That's why they picked that one. But there are about 11 or 12 more enzymes that actually, from a situation of Mm, I guess you have to say the cumulative effect of all of those enzymes actually determines methylation. So MTHFR by itself, they picked it because it's the biggest one. It is not the ultimate determination of the methylation, your ability to methylate. There's so many other factors. There really are. But they figured by picking MTHFR that well, since that one, it must have the major effect. Well, it has an effect. It does contribute, but it's not the complete thing. There's a combination of all those enzymes, the other 12, 11 or 12 or so, that actually determine methylation. So don't be fooled by that. It's a great marketing ploy. Yes, it has something to do with methylation. It is not the only thing to be considered. It is not. And we have done things to confirm methylation. There is a test called the methylation profile or the Samsol ratio test that looks at two pathways. One is your methionine pathway, METH as in methylation, methionine pathway, as well as your folic acid pathway. Okay, because folic acid does indeed methylate in the cytoplasm of the cell. And so between the two, and it shows both pathways, you get a determination of what really is happening in terms of what your chemistry is doing. It's an individualized test. And so the methylation pathway or the SAM-SAL ratio, SAM meaning S-adenosylmethionine, SAL meaning S-adenosylhomocysteine, the ratio between the two, as well as what's going on with the other folic acid and methionine pathways, actually determine methylation. And when these people, it's a doctor's data test, when these people do this test, if there's some flaw, even I'm like, oh no, somebody hit a methylation pathway. It's like, oh God, if there's something wrong with it, I got to read 3 to 4 pages worth of what the heck happened. And they are very specific about what happened to your pathway and what you can do about it. And so it offers some information in terms of how you can fine tune what it is that we write relative to the protocols that we write to kind of correct or push the pathway in direction that's beneficial for the patient. And so we don't just buy MTHFR in terms of what somebody says. We appreciate it that it's there, but we actually very often will need to confirm literally what happened to your pathway so that we can choose appropriately what your protocol really should be. And very often, particularly for those kids that are using folic acid or actually need some folic acid, we'll provide it if that's what it looks like. Okay.
Yeah.
So
Dr. Bowman, are you testing how you're measuring? If somebody asked about measuring folic acid production, underproduction. Are you just measuring folic acid in the blood? Is that how you're measuring to see where their folate is?
when
Obviously, the whole blood
actually,
histamine test will measure methylation, but
mhm. Okay, so the relationship between methylation and folic acid and the histamine test. Histamine has been a great marker for those people who are undermethylated. Generally, it's like the seesaw effect. If histamine is really high, it's a huge chance that methylation is very low. Okay, now the problem or the nuance that comes with that is if people are taking antihistaminic medications, and so that's going to skew the result. If you're taking Zyrtec, Benadryl, Claritin, and or antihistaminic medications like serotonin reuptake inhibitors and atypical antipsychotics, those are, most people don't know it, those are strong antihistamines. And so usually when we see that that is actually on board, we say, you know what, in order for us to confirm methylation, we're really going to have to use something like a methylation profile, because the methylation profile could care less what you're taking. It's just going to tell you what the heck happened to your methylation pathway, whether it's normal, over or under methylated, or low normal, or whatever it is. And that really helps our confidence relative to how we write your protocol. And so it's one of those things where, once again, we're going back to testing, once again, evidence-based, to say that, okay, let's really confirm one way or another on what's going on. And what's good about the methylation profile test is that you can do one, a baseline, and then you can do one a year or two later to find out if the protocol that we wrote actually has pushed your pathway under the bell-shaped curve as opposed to the skews. Okay. And then that helps us a lot in terms of what we need to do for you from supplement protocol standpoint.
Gosh, what a great answer, you guys. So whole blood histamine to check that live methylation status, and the SAMI-SAW ratio methylation to check the methylation pathway. It's looking like you can order, as a provider, you can, or a patient, you can order all these tests through DHA Lab and work through our 5,000 test list. I know a lot of our providers are here today, so I don't need to go into how to do that kind of stuff. And I'm going to stay on after Dr. Bowman leaves to answer any follow-up questions on the testing. We are running a special on the advanced metabolic panel, which does cover pyrrole disorder, methylation, copper, zinc, stuff like that. And I'm going to start answering questions that are coming into the chat, because I am able to stay organized that way. And we're getting so many good ones. Tony Jackson has a question. We have an 8-year-old female diagnosed with DiGeorge. Uh-oh, it just went away. Tony Jackson had a great question. We have an 8-year-old female diagnosed with DiGeorge syndrome. We've been suggested testing to the family. Where would we start? Methylation or copper and zinc?
Oh, no, you need to start with your basic panels, copper, zinc, histamine, urine cryptopyrroles. That would be a good idea.
That's that advanced metabolic panel that we're running a special on. So that'd be a really good, and there's vitamin D in there. There's a whole blood panel, CMP14. There's a ton of stuff. So that would be
absolutely great place to start. A great place to start. It really is, you know. And with DiGeorge, don't forget, you're absolutely dealing with a genetic predisposition there, because that's what that is. Okay, and so you might even want to consider at some point a because of that carbohydrate sort of scenario, even doing something like a food sensitivity reactivity panel to find out what might be insulting to this kid and what might not, you know, and even including candidate applicants, just to find out where this kid is. Okay, just an extra.
We are servicing over 5,000 tests, and we are helping to support millions of patients suffering from anxiety and depression, bipolar disorder, OCD, autism, schizophrenia. I could go on. And we work hand in hand with doctors like Dr. Bowman, like Dr. Menza, like Dr. Walsh, like Dr. Greenblatt, like Dr. So-and-so, Dr. Delaney, who's been on the series, because they all have their specialties. And autism is one that Dr. Bowman works in frequently. You know, it's not just autism. She does everything, but we are looking at the key fundamental important nutrients for neurotransmitter production. We call them the repeat offenders for neurotransmitter production. So that's really what we're looking at. I have a question. This question just makes me super emotional. I'll try not to cry. Dr. Bowman, are there too many mechanisms to pinpoint for even the most proactive parents to turn the boat around, to steer autism in a way that doesn't pan out for the rest of the child's life? Are there any chances? Of course. Makes me want to cry, though.
Oh, I understand. I would say that, first of all, parents just don't quit. They really don't. Moms don't quit, dads don't quit. And I think it's probably in the interest of everyone that when I said that you're in it for the long haul, do what it is that you think that you need to do. Like in terms of if you're working with us, we're going to stay with you to do whatever is necessary. I don't know how to give a timeline on it in terms of how long, say, anything is going to take. We actually try to do the very best that we can do relative to as long as you want to stay with it, we're going to stay with you in terms of making things happen that are for improvement. Many of our patients, and they really stick with us a very long time, and I really haven't seen one yet that hasn't gone to a level of improvement. And to some people, they truly have been so-called flipped into mainstream. Kids who were not verbal are speaking. One of the best examples of what I had seen was a kid who seemed to be just right on the edge of maybe making some progress, but needed a little bit more help. After about 3 weeks of just starting the protocol, had walked up to his mom and said, "Hey, Mom, I love you. This child had been nonverbal for I don't know how many years." And of course, this particular lady said, just simply fainted. I had no idea. And so when we hear stories like that, it's worth everything in the world. And the best of gratitude that we could ever have is to having something like that. Now, guys, really, it's the exception to the rule, 3 weeks, okay? But over time, though, we've heard stories like that and know and have seen and dealt with our patients to the extent that this is really what happens and what really can happen. And so it's a matter of not giving up. Most parents do not want to give up. And if you can stick with it long enough and stay compliant long enough, I really believe in my heart that you will see some level of, or significant level of, I should say, of improvement. It's not something I ever want to see drop. It's just something that you really need to stay in it for the long haul. If you can't, I understand that too, you know. But for the most part, some of our people are in institutions. Some of our people are just at home. The young kids, of course, are at home with their parents and they're working through it. Other folks have moved on to college, to high school, to college, and other professions, and they've done significantly better. So it's something that you just really need to kind of stick out and stick with it. And there will be benefits that kind of come along that way. Mm-hmm.
Mhm. Oh, that was a great answer. Someone asked, do you do telehealth for international patients or do people have to get to you? And I dropped in the Menza Medical URL. You guys, Dr. Bowman and Dr. Menza are taking patients right now. They specialize in all this stuff and
Oh,
they
sure.
do
Yeah.
offer telehealth. So you
Mhm.
can become a patient through their website and I can follow up with that link as well. So it's in the recording.
Absolutely. COVID mandated that we actually get into telehealth, and we were doing a little bit of that anyway. But because we're licensed in really many states, but it's just like East Coast and West Coast, that kind of scenario, whatever, blah blah. But in Illinois, we are more than happy to do a telehealth visit. We would love at least one time, to actually see our patients. Sometimes a picture is worth 1,000 words, but under the circumstances of just what needs to be managed and helped, we are more than willing to do a telehealth visit with a person. And telehealth is one thing, telephone is another. We'll do whatever it takes, but the end result is improvement, no matter what. Mm-hmm.
Mhm. Yeah, for whoever just asked that question, we work with a lot of international providers. And so if Dr. Bowman isn't able to help you, you can email info@dhalab.com and they can hook you up with a provider who's practicing in your area.
Yeah,
We've got them everywhere, the UK, Canada, Switzerland,
true that.
Mexico, we've got them everywhere. So please email us. We're happy to help. If you guys have any questions, you just email info@dhalab.com. This is a question from Alexandra. What are your views on Dr. Amen scans or QEEGs?
Um, can be helpful. Very often, any information that you might have that you want to submit to us relative to a full comprehensive look at whoever it is, that whoever the patient is invited. And very often we have additional information relative to that. We will comment on that. We just need to know what it is. Can it be helpful? Very often it is. Particular, believe it or not, and I did mention this before, there's a percentage of patients with, talk about autism spectrum disorder, where they actually have seizure disorders and whatnot. And for that particular group, there is a slightly different protocol because, believe it or not, anything natural does not have to be safe. And there's some things that can exacerbate seizure disorder if it exists. Okay. And so those are the kind of things that if we have that information, we will take it into consideration. And this is where we put on our mainstream hat with whatever information that you have to appropriate whatever protocols we think are needed. So yeah, we understand that. We just need to see it and find out what the heck is pertinent or pertinent positive to our treatment option. Okay, so yeah,
Mhm.
consider it. We're okay with anything you have.
Yeah, Dr. Robin, people have questions about working with Mensa Medical, who can I refer them to? Is there an email I can drop that they can ask specific questions?
Oh, absolutely.
Nurse@mensamedical.com.
Nurse at mensahmedical.com is the best thing to do. We have three nurses. One, two, three. Yeah, we have three nurses that are excellent. Kim Jacobek, who's been doing this and worked for the Pfeiffer Treatment Center with us, with Dr. Walsh, probably has been doing this for 35 years plus. An amazing nurse. So if your cases are extremely complex, that's who you want to tap. But nurse at mensahmedical.com is not a bad way to go, or just mensahmedical.com, and that'll be directed to probably Diane.
Mhm.
We'll do distributing in terms of who it is you want or need to see. Any of that
Mhm.
would be good. Any way you can get in touch with us by way of our website would be fine. Go to our website. There's a lot of
Mhm.
others in our website as well. In terms of the research that we have done, we do have a researcher that works with us actually out of Maryland. AJ Rousseau has been working with us for many, many, many years in terms of the research to help to back up what it is that we do. We are also faculty on the faculty of Chicago Medical School, believe it or not. And so we're trying to keep both, kind of stay up on top of it with our mainstream as well as our, if you want to call it functional medicine or integrative health hats as well. It is an alternative sort of a medicine. We realize that mainstream does not have all the answers. And so between what it is that we know and our mainstream hats, we make all considerations. Consider this. People who have other conditions, this is where it becomes really important that we have our MD hats on. Um, Particular conditions, whether it's a seizure disorder or something else that's going on with you, whether or not you have hypertension, whether or not you have whatever the heck is going on with you from a physiologic standpoint, we're going to make those considerations and also try to support those situations as well. So this is, and I don't know if we even fall under a particular category of functional medicine and or integrative health. We certainly do all the above. But it's one of those things where we take everything under consideration, everything. It's helpful to have known all of it in order to manage appropriately. Because there's some things you cannot do from a natural standpoint that do not go with that patient's condition. For instance, I'll just give you one. And this is a major player. Any kid that has a seizure disorder, okay, one, manganese lowers dopamine. If you have a Parkinson's disease, if you have tics, Tourette's, or anything that looks like that, or movement disorder, manganese is not for you. It will make you worse and cause your exacerbations to be very frequent. Those are things you really need to know. And that's both mainstream and what it is that we do. And so then that's just one scenario. But we take everything into consideration when it is we're trying to figure out what it is we need to do for you from a nutrient scenario or nutrient prescription standpoint. So there's a lot of things we need to know. There are nuances. There's certainly I call it an artful touch in terms of what it is we do because of what it is that we know. We know medications extremely well. So whether 50% of our patients come to us on medication, the pharmacology, we know that, very well trained in it. And we know what's going to do for you. We know how it's going to deplete you of certain things that you need. And so just FYI, we're taking all that stuff into consideration. We're just not flying by the seat of our pants. Not at all. So,
Mhm.
mhm.
You talked a little bit about metal dysregulation or metal toxicity and autism. Do
Mhm.
you believe pyrrole disorder is caused by heavy metal toxicity? And do you address heavy metals while you're treating pyrroles?
Of course we do. Absolutely we do. We basically try to rev up your metallothionein, so that's fixed, okay? And we have ways that we do that. In terms of, we need to see how bad it is. We need to see exactly what it is. Some metals matter, some metals don't matter as much as you think. For instance, we've seen some people with high zirconium levels. So unless they're producing diamonds, it really doesn't matter, okay? And so it just depends.
Wouldn't that be nice?
Exactly. That would be fantastic. But no, yes, we look at that. Of course we do. And what we don't do is we try to regulate and make metallothionein do its job as opposed to chelate. If you chelate, what you're doing is taking out the good stuff with the bad stuff, and then you have a problem of trying to put the good stuff back in a timely manner, and that doesn't really work. And so we try to regulate and get your metallothionein to do what it's supposed to do. And that way, you're not just taking out all the good stuff with the bad stuff at the same time. That can be horrible. We have had and known of, not us actually, but we have known of some colleagues that unfortunately have had some children to literally die because they chelated too much and weren't able to replace. That's not where we want to go. Okay. And so
Mhm.
regulation is one thing, chelating is another thing. And so you have to be extremely careful in terms of what it is that you're doing. So
Mhm.
you take it very, very, very seriously.
For those of you who aren't as familiar with pyrrole disorder, the cryptopyrrole test is a simple urine test, at-home urine test. So it's really good for children because, you know, if they struggle to go get their blood work done, the pyrrole at-home test can be really useful for them. At a young age, one provider actually asked, "Are you able to test for pyrroles in a baby who is wearing diapers? How do you do that?"
Oh, absolutely. You know, we have a little bag, you know, like whenever you need
Do
to
you
use
put the bag in the diaper? I'm curious how
the
this
bag
works
over the
myself.
little genitalia and they eventually will go. Okay. And
Okay.
yeah, it's as simple as that. We've thought of everything, guys. We've thought of everything. So don't forget though, pyrrole disorder is a disorder of stress intolerance. And stress in terms of your body, it cannot tell between emotional duress or physiology, just this physiology stress. Put it like that. In other words, you could break your leg. That's going to be stress. And your body doesn't know the difference between that and bereavement, let's say. It's like, oh, stress is stress. And that's all it knows. And there's this tendency to produce pyrroles when you're under stress. Your body tries to help you deal with it. It will do whatever is necessary to keep you in a mode of functionality. But when you're under stress, you're burning through B6 and zinc. You are. If you hit rock bottom, maybe you didn't have enough to begin with, then you're going to be in trouble because it tends to be just a continual spiral down of non-functionality, and you'll get to a point of paralyzed to function. Paralyzed to function feels like, oh, people on a game show that are brilliant and they're answering questions. And for some reason, they just can't think of the answer. You know, they can't think of it. They're paralyzed to process information. All of us have done the, oh, maybe at the cocktail party or whatever party you were at, and this is your mother standing next to her and you can't think of her name. Okay. It's kind of like, you know, it's one of those having a moment of pyroluria or stress intolerance to the point that you're just paralyzed to function, you know, or situations have been so extremely intense. Whatever that is, I mean, it really could be a situation where anybody would have an issue. Maybe you were rear-ended, and it just kind of shocks you out of your gourd. Okay. Those are situations that we can understand why people behave the way they do. But a continual sort of scenario like that,
That
way
was such
too
a
longer
great
than it
way
needs to be
to
in
wrap
terms of you
up. You
coming
know, you're
back to
talking about
baseline to
that
be able to process
biochemical
information and move through your
individuality. You're
problems.
talking about lab testing, no
It's
matter
an
what you're
issue.
seeing.
Okay.
Test, you
And so
guys.
being paralyzed to function in that kind of way says that you probably need some help. And maybe if we just kind of took some labs and find out what's going on with you. Oh my gosh, you're pyroluria. Well, that's part of the problem. You can't produce neurotransmitters to give you an overall sense of well-being. You can't produce neurotransmitters like gamma aminobutyric acid to help you calm yourself in a timely manner to help you just kind of get through this. Okay. So it's one of those scenarios that, once again, through testing, we find out where the deficiencies are, or even where the overkill is. And the idea is to put you into balance because everything isn't deficiency. Some things are just there's too much of it. Okay. So we just try to figure out what to do with it.
Thanks so much,
Okay.
Dr.
Till
Bowman.
next time. Thank you. I appreciate the honor. I do.
She's amazing, you guys. She is amazing. I'm going to share my screen.